So thank you for inviting me to talk. I've actually moved across to the Alfred Hospital, which is one of the biggest public centres in Australia, and this is my experience. At St Vincent's, I used Pascal exclusively, and then at the Alfred, I used both devices. So we use both devices at the Alfred. Just a bit of background data. So in respect to CLASP, there was the CLASP study, and we have 2-year outcome data for this now. This was a single-arm, multi-centre study at 14 sites, including several in Australia, from 2017 to 2019. And in general, at the 2-year point, there was an 80% survival and 85% freedom from heart failure rehospitalisation. There was a significant reduction in mitral regurgitation of 1 or less in almost 80% of patients. There was some LV remodeling also, and then there was a sustained improvement or benefit in heart failure symptoms. So this was the first study that showed that this was a fantastic device. Then the true head-to-head trial was the CLASP 2D randomized controlled trial. This compared Pascal to MitraClip in those patients with prohibitive surgical risk and mitral regurgitation of 3 plus or more. There was 300 patients, of which it was a 2-to-1 randomization, and this was the true head-to-head. From a procedural aspect, there was no significant difference in major procedural outcomes. There was a difference in device time or procedure time in those patients that underwent Pascal, but as the operators became more experienced, these device times reduced. Interestingly, the devices used in this study, a fifth of those used the second generation Pascal precision system, whereas in the MitraClip arm, approximately 70% used the generation 4 device with the independent grasping. So it'd be interesting to see what the data is with more patients having the precision system. This is a very busy slide, but essentially the Class 2 1-year outcomes presented last year demonstrated that Pascal was non-inferior to MitraClip in the composite safety endpoints of death, stroke, MI, renal replacement, and including re-intervention. At 1 year, there was a high survival and obviously low heart failure hospitalisation rate. There was a significant, down in the bottom, top right, sorry, a significant and sustained reduction in mitral regurgitation and very stable transmitral gradients. With regards to the bottom left-hand corner, there was a meaningful and sustained improvement in functional and quality of life outcomes, and there was evidence that there was LV remodeling as assessed by the core lab, which is good for the therapy in general. So what is the Pascal implant? The acronym for Pascal, and my understanding is it stands for paddles, spacer, clasps, and alfieri, which seems like someone spent a lot of time trying to come up with that. There are 2 devices. There is the Pascal ACE system and then there is the Pascal, which was the original system, or called P10. There are some common features of both devices. Both of the devices are a nitinol frame, and it has a passive closure, and is therefore a little bit more flexible and gentler on the leaflets, and does move with cardiac contraction and relaxation, unlike the MitraClip, which is a active and quite a fixed closure system. Both devices have a spacer to reduce the effective regurgitant orifice. They have contoured paddles to reduce the stress on the leaflets. The clasps are able to have independent leaflet grasping, which was their unique feature when Pascal first came. Obviously now G4 has that too. The retention elements allow for multiple grasps without leaflet trauma. And a key thing about the Pascal system, both the ACE and the P10, is that you can elongate. And as Dr. Cho presented in those great commissural cases, this does provide an element of safety in those complex cases. A brief note on the atraumatic clasp design. You'll see that these horizontal clips here, there's 4 that are horizontally placed. and they minimize tissue damage, and they are orientated with a collagen fiber orientation. And one of the things to think about is when you pull up on the device, there's no interaction with the leaflet. And it gives you the confidence that you won't cause tissue damage. And in those complex cases where you have to have multiple attempts at grasping the leaflets, there will be no significant damage. So which device? Up here is the ACE device, and just a brief on the dimensions. The ACE is 6 millimeters in width. The spacer is 2 millimeters. The leaflet arms are 26 wingspan, so it's a very long, similar to the XTW. The Pascal or the P10 device is 10 millimeters in width, and the spacer is 5 millimeters. One thing to think about with the P10 is rather than being an edge-to-edge repair, it's more an edge-to-spacer. So you bring the leaflets to the spacer and therefore have less tension on the leaflets. And it also allows you to have a larger orifice area when delivered. For me, I use the P10 or consider about the P10, the 10 millimeter device in functional MR cases, those with shorter and restricted leaflets, and potentially those patients with a higher pre-TEER gradient. As I said, I don't want to pull the leaflets in and increase the gradient. The ACE device I generally use on the degenerative cases, particularly with the commissural jets, also to navigate this thinner device through dense chordae. And the way to think about it is if you have more tissue or longer leaflets, then you use the ACE device. We have used cases where we mix and match. Sometimes I think about these FMR cases and whether putting in two ACE devices will have an annuloplasty effect. So it does give you a lot of options using this system. And sorry, this is another thing about over the right of the screen, the elongation property that I've discussed. You really truly can elongate the device and get out of the ventricle if you're interacting with chordae. I'd like to just present a couple of cases, if I may. One is DB. She's an 83-year-old female that was referred to me from our external referring hospitals and had 3 recurrent heart failure admissions. She has a history of bronchiectasis and a left lobectomy in the 1980s, and the lung doctors were confident that was stable. She had mild coronary disease. Her ECG demonstrated sinus rhythm. The toe demonstrated normal biventricular size and systolic function. There was moderate left atrial enlargement. And in those people with small left atria, we are concerned about navigating down to the valve, but this system with its flexibility, and it is very easy to navigate in that tight anatomy. And she had a prolapse of P1, P2 with flail of the P2 and a severely anteriorly directed jet. So we presented our MDT, and our consensus was to use the ACE device, our rationale being that the commissural jet may be challenging to navigate and we could risk caudal entanglement. And this was actually the first case I used the system and brought the system to the Alfred. And so this was a great introduction for my colleagues to see the benefits of the ACE and the PASCAL system relative to the MitraClip. Here we have the imaging. You can obviously see that prolapsing segment. You can see the severe MR that's anteriorly directed. And then down here, you can see the pathology out P1, P2, so very far out, and the severe MR on colour. As discussed, we go through the gradients in the pulmonary vein flow. So the pre-TEER gradient was 2. She did have pulmonary reversal. Here is just coming down with the clasps. On the image on the left, we have simultaneous leaflet grasping. So you can see it's very easy with great imaging or images to see the leaflets the clasps coming down onto the leaflet, which is critical in this therapy. And then on the right, you can see there is independent leaflet grasping of the posterior leaflet. After our initial grasp, what we call the Tarzan maneuver, and we swung across to grasp that posterior leaflet. Here is our closing and then assessing all our usual for tissue bridge, seeing that we've had a good result from a colour point of view, and then making sure we have adequate tissue. We now routinely measure the left atrial pressure, and she had a drop from 50 down to 20s based on this result. Here we're assessing the tissue bridge in the colour 3D, and then you can see the reduction in MR. So an outstanding result. Mean gradient 3, no flow reversal in the pulmonary. This is a key thing, I think, which is one of the differences I've observed between the two systems, is there is a predictable release with the PASCAL system. The device is actually attached on the atrial aspect of the implant, as opposed to the MitraClip, which extends further down into the ventricular aspect. And a key thing is when you deploy this system, what you're left with pre-deployment and then post-deployment is exactly the same. We've been very pleased with this. What's the update in the PASCAL Precision device? Most of it is the same in the sense the guide sheath to use for anterior and posterior navigation with the flex knob. The steerable handle is the same also, that helps with medial and lateral. And then the implant catheter is very different. We have these two clasp sliders. The dark grey is usually the posterior. These can move independently when you unlatch the lock. You've obviously got the closure knob. And then if you remove the implant release cover, you have the suture locks and then the now ratcheted device release knob, which you now no longer have to hold that tension. The difference between this device is that it is essentially, you could do this for one operator. And for those that are familiar with the Edwards system, it is very intuitive. Here is a case of one of our precision that we did last week. 78-year-old male, recurrent heart failure, terrible, not moderate severe coronary disease, had a CTO of the LAD with severe LV dysfunction, an ejection fraction of 30%. And he had a severe MR with a myxomatous valve and a posterior leaflet prolapse P2 into P1 subsegmental flare, and probably mixed given his LV was dilated when we further evaluated this on the day. We decided to perform PASCAL ACE. You'll see here our multiplanar reconstruction, which we're increasingly using now. The flail, the prolapse width was 17 millimeters, so very wide, and we were not very confident that we would get down to mild. But this gentleman is from Borneo and wanted to return to his family and have the best quality of life possible. And so we stepped up and did this procedure. And we were amazed with this result. We used 2 ACE devices, which you can see here side by side, and he has mild mitral regurgitation. So you can really see in complex anatomies, this system is highly successful. This video, I borrowed this from Sam Dawkins, and this is what he presented at London Valves. You'll see the system here. I just want to show you the ability and the ease of torquing the device. You'll see he's opening up the system, and then he's going to torque from 3 o'clock round to 12 o'clock. And it really is one-to-one torque. And you no longer need to necessarily hold on to the steerable guide. You can just torque the implant catheter. And my colleagues that are now experiencing PASCAL at the Alfred are constantly amazed at how easy it is to torque this system. And so in summary, my experience with PASCAL has been very positive, as my colleagues at the Alfred that are new to the system. We obviously have great safety and efficacy data, independent and then also compared to MitraClip. I think the system is more intuitive and there is less what I call knobology. It is far easier to use. We have 2 implant devices that allow treatment of a wide spectrum of disease. The system is incredibly stable. It is very steerable with those 3 devices that allow you the full range of motion. It is very accurate in control, and the one-to-one torque is definitely something that should be seen. We obviously have the independent leaflet grasping that is carried over into generation 2. The ability to elongate, particularly in those dense chordae or commissural jets, is very useful, and you can navigate out safely. And the key thing is this predictable result. When I release the implant, it is exactly the same as what I had when the implant was on. So once again, I'd like to thank you for inviting me to talk, and I hope you found this useful. Thank you very much.